what do you think of complex PTSD? Because I know that's a really hot topic being debated right now.
I don't respect that conceptualization. First of all, the name I think is kind of insulting to post-traumatic stress disorder because people are thinking that it is divided by severity, that there's regular, typical PTSD that's easy to treat. And then there's this harder, more complicated PTSD to treat, which isn't very accurate. In fact, the traditional PTSD diagnosis actually has more of that startle response, more of the central nervous system distress, miscalibrated central nervous system. CPTSD is mostly shown up in the realm of, how they're connecting to other people, how they're relating to other people. If you actually climb up the severe ladder, there is virtually no difference between the conceptualization of PTSD, severe PTSD, and severe complex PTSD. If you put them at the severe level, the difference is entirely in personality.
Yeah, complex PTSD goes back to the work of Judith Herman in the early 1990s. When Herman was writing, she was really writing about um, problems that really look and feel very much like borderline personality disorder. And so, and actually, if you read Herman's writings and if you watch her lectures and the like, you will soon see that she was actually looking um, to do away with the borderline construct. She saw it as stigmatizing, not as taking into account the trauma histories of these patients and the like. And when we look at the data, patients with borderline personality disorder do have very high rates of childhood abuse, neglect, and other forms of mistreatment in early life. Now, the problem with complex post-traumatic stress disorder is also that it seems to lack discriminant validity when you consider the fact that what CPTSD may capture is actually what Mary Zannarini has called subsyndromal borderline personality disorder. So if you look at CPTSD as a construct, there's a lot of overlap with borderline personality disorder. What you don't see as much of is instability in interpersonal relationships. You see the construct actually, as theorized, actually says that patients with complex trauma tend to avoid relationships. Now, this is the exact same syndrome, more or less, that Mary Zannarini years ago described as subsyndromal borderline personality disorder, on the same continuum as BPD, but it doesn't reach the threshold for diagnosis of full-blown borderline personality disorder. And some people now, I believe, are calling this complex trauma. Now, even complex trauma researchers um, admit that that CPTSD and BPD may exist on the same continuum, with CPTSD representing the less severe form of the pathology, and BPD referring to the more extreme form or more severe
Hmm.
form of the pathology.
Some people are saying that it's exclusive, that it's just a reconceptualization of borderline personality disorder. I don't think that's true. I think that there are multiple different personality organizations that could wrap itself around repeated cumulative traumatic experiences, especially in childhood, where often personality disorders develop.
My problem, and I've written a little bit with Joel Paris in Canada on this, is that if we introduce CPTSD formally in the United States, it's already recognized overseas. If we introduce it in DSM, my sense is that a lot of patients with borderline personality disorder who would be referred to or for evidence-based therapies for BPD are actually going to be diagnosed or perhaps misdiagnosed with complex trauma
Hmm.
and referred for vague and generic trauma therapies that may not target at all the core problems that we see in borderline personality disorder. I think there's an additional risk, which is that a trauma treatment may actually reinforce some of the patient's externalizing defenses, meaning their tendency to blame others and to blame the outside world for a lot of the problems that originate as a result of their own condition and behaviors. And so externalizing defenses are very common in BPD. And so if we treat the patient as if they're simply a victim of external circumstance and makes no contribution to their problems, their ongoing problems in life, then I think we risk really mistreating that patient, and we may actually reinforce the very problems that they bring into therapy. And so John Gunderson's written about this. Otto Kernberg has talked about the different countertransference reactions in therapists that may lead them to see the patient as a helpless, hopeless, sort of passive victim.
Is there some motivation you think behind the people pushing this? It seems like they're I'm not really sure. Like maybe like pushing CPTSD as a way to destigmatize borderline. I don't know.
I actually think that that is one of the motivations. There was a motivation to do that, I want to say about 20 years ago. They were going to call it childhood trauma disorder, and it was kind of quashed really quickly because all personality disorders are childhood trauma disorder to a certain extent. And I think this is just another attempt at that. The thing is that they have broadened it. And the more we broaden a diagnosis, the more it has concept creep. It is absorbing a lot of what we already understand from PTSD. I've already said it a handful of times that one of the features that PTSD is failing to capture is cumulative repetitive trauma. That's only in cause. The symptoms are not different. The attempt to really try to identify what symptoms are and are not traumatic, I think is kind of a waste of time. It takes away from identifying, well, what's actually going on and how can we help it?
The other problem with complex trauma, from my perspective, is that it fails to incorporate the genetic research on borderline personality disorder. We know the heritability of BPD is roughly 45 or 50%, going back to Torgerson's work in 2000, and now is well established in the BPD research community. We know that there's a significant heritability to borderline personality disorder, whether that's an innate aggression or interpersonal hypersensitivity. The child brings into the world a temperament that colors and may distort their perceptions, and it may influence the way caregivers and parents treat the child. As any parent will tell you, children differ in terms of temperament. They come into the world very differently sometimes than their siblings do. And so to put the focus on trauma as the sole etiological factor in borderline personality disorder, I think ignores the multi-causal nature of BPD: genes, temperament, early environment, biology, the patient's own constitution, and their own psychological makeup. Complex trauma has a way of flattening all of that and saying that you have this disorder because of trauma. And that's the only reason you have this disorder, which we actually know is just not true. It's just not empirically true. There's lots of variables at play in terms of understanding why a person develops BPD. Many patients, 80% of patients who have traumatic childhoods don't develop any psychopathology in adulthood. That's the work of Joel Paris. 20% do, but 80% of people who experience trauma in childhood don't develop any discernible psychopathology. And so I think complex trauma has a tendency to flatten all of the complexity that we know about human personality and human psychology. I actually have a paper in press now at the American Journal of Psychotherapy that touches on some of these ideas on avoiding oversimplification. I think there's great appeal to oversimplified narratives in therapy where we just want to say X occurred because of Y, or Y occurred because of X, when in reality things are much more complex.
Most of what CPTSD is conceptualizing is some of post-traumatic stress disorder and some pathological personality organization. And I think our current model is more descriptive. It also provides more utility in identifying what the symptoms are and what is the healthiest track to treat it.